Good day, my dear students. Welcome to Rapid Revision in Pathology. Owing to want of time, I have restricted myself to the hematology part of your portions. Even then, you must be observing that I am pertinently dividing the WBCs into the leukemias and then the rest. In today's class, I shall be dealing with the multiple myeloma and lymphoma. These are my references. And my fervent plea to you people shall be, do not change your book now. That is not correct. So, these are the important instructions that you shall and will follow. Do not change your book. Mark the important points in your text and write what is missing. Go to the R.A.T.S for the extended description and then back again to your text. This shall be the modus operandi. Secondly, theory should not be separated from slides and slides must not be separated from charts or from viva voce also. All of them are very intricately interlinked. Myeloma for the day. On the screen, I will not be wasting a single picture. I am finding that there are large ovoid cells. Oval is a two-dimensional word. Ovoid is a three-dimensional word. The nucleus is eccentric and there are multiple dots which provide a cartwheel-like appearance. Also, if I observe carefully, there will be a perinuclear halo. The cytoplasm is somewhat amphiphilic or bluish gray, and there can be some eosinophilic inclusions called Russell's bodies. That will be the classical one. Look at the picture, spend some time. You will be able to describe it yourself. What we are seeing in the peripheral blood will be this kind of a picture. The peripheral blood picture is not diagnostic in monoclonal gammopathy, which means multiple myeloma or Waldenstrom's macroglobulinemia, two disorders. Here, however, what I am seeing is the RBC are in chains or a rouleau formation. That is one. Secondly, the background usually is colorless, but here I am finding a bluish background due to the precipitation of protein. After all, plasma cells produce immunoglobulins, and immunoglobulins are proteins, and hence this color. Two important findings shall be there in the peripheral blood. One, ESR will be markedly increased, nearly 100 millimeters per hour. Two, there will be a hyperproteinemia. These are two important findings. Otherwise, this is one disorder purely based on the bone marrow diagnosis. So that is a picture over here. And these are again our friends, the plasma cells. So they are ovoid. The cytoplasm is somewhat grayish blue. The nucleus is eccentric. There is a cartwheel appearance of the chromatin, perinuclear halo. Sometimes cells can be binucleated. Also, we will be seeing some immature cells called plasmablasts. So that will be the picture over here. And this kind of a picture can be given to you as a case history. Punched out appearance, osteolytic lesions seen in the flat bones, ribs, skull, vertebrae, pelvis. Classical. Secondly, you find that it is not a disorder in a patient less than 45 years of age. Usually the patient is beyond 55, 60 years. And even at autopsy, the holes in the skull would be made out. That will be the radiological findings. So we have seen two things, peripheral blood, then radiology. And these are the variations of the plasma cells which you people shall memorize. It will be given in your book. Kindly mark them or jot them down. Also, the Russell's bodies which are inclusions. Descriptions are very scanty in your answers. Therefore, you increase it. What should we do is the bone marrow. The bone marrow in a case of multiple myeloma consists mainly of the plasma cells. Look at this one. I think nearly 80% of the answer is plasma cells. Cellularity, it can be normal or increased. All the others are suppressed because this fellow is increased, the plasma cells. Again, you describe the plasma cell, you mention the cartwheel chromatin, eccentric nucleus, etc. Also, the variants of the plasma cells and the inclusions in the cytoplasm called the Russell's bodies. Sometimes there will be immature cells having a more pinkish cytoplasm, eosinophilic cytoplasm. Cells will be around. They are called as plasmablast and they are also described as flame cells. Flame is red, these cells are also red. Binucleation, multinucleations are all pointers towards myeloma. These are the other suppressed lineages. The differential diagnosis is one thing. Normally, in any kind of leukemia, the bone marrow should have 30% abnormal cells. Acute myeloid leukemia, acute lymphoblastic leukemia, 30% blast in the peripheral, in the bone marrow. And here also the bone marrow should be having 30% plasma cells. There are some diseases like syphilis, tuberculosis, etc., where there can be up to 10% plasma cells, which is not indicative of multiple myeloma. Again, there can be abnormal protein, there can be a Bence-Jones protein, etc. You people will have to describe the Bence-Jones protein. We shall come to it if time permits. Look at this one. This is called a mott cell with a grape-like cluster in the cytoplasm. And again, the pelvis showing multiple moth-eaten appearance and classical of osteolysis. So it occurs in the flat bones in the old ages. Pathological fracture can be a feature. ESR will be massively increased. These points, again, I will be summarizing at another session so that it will guide you people when the history is given. The kidney is one organ which can be affected, in which you can find abnormal protein called the Bence-Jones protein, supposed to be composed of the kappa and the lambda chains, etc. Fine. There can be calcification. Amyloidosis is a very important feature in the kidney, asked as an MCQ, and if you do mention this, you score a point in this. Again, I would like you people to kindly memorize this particular list, the major criteria and the minor criteria. If it is given in your books, fine. And there should be at least one major and one minor criteria or three minor criteria, which will be diagnostic. For example, there can be an increase in the serum calcium. There can be osteolysis. And there can be abnormal immunoglobulins. All these are supposed to be there. And you will be able to demonstrate it by means of urine electrophoresis. So these are some of the criteria for diagnosis. Kindly memorize. Amyloidosis, you people should mention. ESR will be increased. And this is the electrophoresis in which you have got an M band or a myeloma protein. Normally, it is not raised to that extent, whereas in this case, it is increased, clearly diagnostic. I think this can be given in the chart also for you people. So, the cell picture, ESR, and the electrophoresis, clearly the diagnosis is there. But then, we should be prepared with the answers and not stare at the examiner when questions are asked. This is a superb picture that is there from a text which I had taken from elsewhere also. So this is important for us. Look at this one. There can be lytic lesions. There can be the monoclonal gammopathy. The M protein is there. Patient can be prone for infections. Pathological fractures, particularly in the flat bones. There can be a proteinuria, renal failure, obviously. And patient can be having anemia because of the infiltration, urine Bence-Jones protein. So these are important things. I think this diagram will summarize, but these alone are not sufficient. I would like you people to have a professional description of the bone marrow myeloma cell. So this is our friend, the Hodgkin's lymphoma. So this is the next one. I had finished multiple myeloma. Another question in the myeloma can be the Waldenstrom's macroglobulinemia, composed of abnormal B cells. But then that is unlikely to be a question for you people. Just have it in the corner of your mind. In case it comes, it is your common sense to apply the facts. Round B cells will be seen, ESR is increased, anemia will be there, and there will be the viscosity of the blood. So coming back to the lymphoma. So this is a lymph node. On cutting open the lymph node, it is solid, and people used to describe it as a cut potato appearance or a fish flesh appearance. Classical. These words may be given in your MCQ or in the history. Catch hold of them. Secondly, this can be an identical picture that is given in the chart. So lymph node, normally it has got large cells in the center and smaller cells in the periphery, forming a follicle, lymphoid follicles. Multiple follicles will be there, which is totally absent in a case of a lymphoma. This is called effacement of architecture. 1 point. So lymph nodes are enlarged, they show effacement of architecture. Secondly, when I look at it, forget this. This, of course, is the answer, but concentrate on other things. I am seeing the lymphocytes. I am seeing the large pale histiocytes. I am finding our friend, the plasma cell with eccentric nucleus. There may be eosinophils. This is called a pleomorphic population. Effacement of architecture, pleomorphic population, and the classical Reed-Sternberg cell or the Dorothy Reed-Sternberg cell. This is composed of bilobe nucleus or binucleated cells. So there are two nuclei over here. And if you look at one, the other is supposed to be a mirror image of it. Mirror image nuclei is a word that can be given. If the nuclei are going to be round and then there are the nucleoli, they will be eosinophilic in H&E state. That will give you an owl-eyed appearance. Owl-eyed appearance is classical of Hodgkin's lymphoma. Mirror image nuclei, classical of Hodgkin's. Pleomorphic population, classical of Hodgkin's. Effacement of architecture, classical of Hodgkin's. Stress, sweat it out. This is the last lab. So you people will have to do it. And coming to the description, there are two types. No, there is the earlier one, the lymphocyte predominant, then lymphocyte depleted, mixed cellularity, nodular sclerosis. And there is also a WHO classification, which you people will have to read up. Your Robbins will be giving you, and your other textbooks will be giving you the various types of the Reed-Sternberg cells. Any of this can be asked as an ultrasound. Lacunar cells are seen. So even otherwise, if Hodgkin's comes as a question for you people, the student who mentions the variations or the variants will definitely score the marks. So clinically, you find that the patient will be having a fever, what is called as a Pell-Epstein type of fever. That is what I mentioned. It is biphasic. So it will be present at one particular age, then it is absent, then it is again present at another age. Other features such as lymph node enlargement, fever, etc. can be there. Reed-Sternberg cell will be the stalmark of your answer. Here again, I have tried to describe it to the best of my ability, but then it is one page. It is my book, the one page that I have taken most of the text from. And The other textbooks, Robbins, are all wonderful sources for you people to refer. Do not change your. And these are incidentally the markers for Hodgkin's. Nowadays, markers need not be asked for undergraduates, but if you do mention, you score a point for this. This will be the staging. So there are 4 stages of it, comes under what is called as the Ann Arbor staging. So initially you find that one group of node is involved. And second one is there can be an organ or 2 groups of nodes, but on the same side of the diaphragm. The third one will be they are found on either side of the diaphragm. And the fourth one will be there will be the involvement of the bone. So these are the 4 grades which you people will have to mention. Quite easy with the picture. That is why I said be very slow, be deliberate. It is not difficult at all. One side of the diaphragm, again one side of the diaphragm, both sides of the diaphragm, involvement of the bone. So, and the organism is supposed to be the Epstein-Barr virus, which can be used elsewhere also. Nasopharyngeal carcinoma, it is Epstein-Barr. There is so much of theory in it, I am not going to go into it. This is another lymphoma which usually is not asked for the students, undergraduates, the non-Hodgkin's lymphoma. Here again, I am finding effacement of architecture. No follicles are there. The cells may be small, they may be large, they may be a mixture. So in this case, it is diffuse. So it can be small cell diffuse, mixed small and large diffuse, or large cell diffuse. If you people mention this much, it is more than enough. Massive lymph node enlargement will be present. And also the organ. This is a spleen that is showing multiple nodules of the tumor, the non-Hodgkin's lymphoma. Again, it is fish flesh-like in appearance. As though you have cut a fish. That is the appearance. So lymph node enlargement. Sometimes there can be extranodal involvement also. Extranodal lymphoma, maltoma, galtoma, etc. That can be present. So non-Hodgkin's, just have it in your mind. This can be asked as a question. This, of course, comes under the non-Hodgkin's lymphoma. We have seen it in the leukemia L3, ALL L3, or the Burkitt's counterpart. So this is the Burkitt's lymphoma. I would like you people to kindly go back to your text and read. What is the cause? What are the types of Burkitt's lymphoma? And usually you find that the cervical lymph nodes or the facial-maxillary region are involved. And here there is a population of darkly staining cells, and I'm finding macrophages which are phagocytosing. These are called as tingible body macrophages. But looking at it, it is as though the entire background is dark and these are shining as stars in the sky. So this is called a starry sky pattern, classical of Burkitt's lymphoma. The details of it I have given over here, and this is the L3 counterpart, this diagram I had shown you earlier. Africa, Epstein-Barr virus, etc. Starry sky pattern, all these are given. If you people write this much, it is more than enough. There can be other sites. Go to your text and read this up. Also, you find that there can be a translocation, reciprocal translocation. From 8, it goes to 14. From 14, it goes to 8. So there is a translocation between 8 and 14 in the long segments, which is called the reciprocal translocation. Definitely, you people can mention or you can draw a diagram of it. And please do remember, repetition is the mother of skill. Initially, it will consume time, but later on, it will not consume even 1/4 of the time or even 1/10 of the time. So please repeat, do not bother about time, do not look back. Be slow, persistent, listen, go back to the book, identify, again go back to R.A.T.S, go back to the book. This should be the mode of preparation. Thank you.